To those who I know already, hello, and to those who I haven't met, I hope to meet you sometime face to face. Thank you very much, Pat. As Pat mentioned, the work that I'm going to present today relates to a recent publication in the Lancet Oncology about the public reporting of outcomes in radiation oncology. And I think what's exciting is that we've been a bit far behind compared to our surgical colleagues, both in terms of audit, quality improvement, but also this notion of reporting outcomes publicly to direct patient choice for transparency, but I think more and more in this era about value-based healthcare. And I wanted to say our experience from the UK, particularly with this program, which is the first of its kind internationally. So if I hopefully get the presentation up, if Pat can nod to me and say she can see it okay.
I can see it, lovely.
Good, good, that's always a good start. So yes, a broad overview. So where are we at with outcome reporting? So in terms of the UK, let me just say that, so I know in the early 90s or late 80s, I mean, some of the sort of doyens of health services research in the US were coming up with this notion of outcomes reporting, and it was very much used for coronary artery bypass grafting, cardiac care. How do you drive up standards or improve it? In the UK, it came much later. So this was back in Tony Blair's government, early 2000s. You know, lots of things about targets. How do you motivate doctors? How do you improve quality? And this notion of choice and competition came in 2008. And it was really the thought that actually, although the NHS funds healthcare, if money was to follow the patient and the patient had the opportunity to choose where they have that treatment, the movement of money could act as a nudge. It was essentially a nudge policy to improve outcomes if they were losing patients. In addition, at the same time, there was meant to be live public reporting of outcomes to inform that decision making. And so there was a lot of political commitment at that time to actually reporting those outcomes and creating the infrastructure to do so. To date, we have the Clinical Outcomes Programme, which started in 2013, and that's by the Health Quality Improvement Partnership. That's funded through the NHS, and there are many publicly available websites giving different types of, whether it's cancer data or data related to orthopedic care, for instance. So moving forward, what were the types of outcomes we were getting? Now, to begin with, it was very much mortality rate. So you have a hospital and they would say, well, actually, all things being equal, this is what the standardized mortality rate is. Now, that in itself doesn't give you any description of the quality of the individual treatment, but what it does and how I describe it is as a tin opener. And the big case that happened was in the UK, was Mid Staffordshire Hospital. So this was a centre that was found to have higher rates of mortality for patients compared to other hospitals. This then became an alert mechanism for a thorough review. After that review, it did find issues with care. They got Don Berwick over from the US to do an actual review of all the healthcare processes. And actually Mid Staffordshire doesn't exist anymore. The hospital has changed, the sites, everything. But without those outcomes, you have centres which have been operating with poor outcomes or poor quality of care continuing unless there is some way of measuring what that quality is. So that's on a broad sense, that's mortality rates. But how do we get something more specific about that individual or that team offering treatment for that patient? And so that's where surgery has really come into its own for many years. So whether it's orthopedics, hip replacement, so hip revision rates, there's also a registry which reports the patient-reported outcome measures. So every patient in the NHS, when they have their hip surgery, is asked to complete a patient-reported outcome measure, and those are publicly available to be able to use or to make informed decisions about where people might consider having treatment. And there's also adult cardiac surgery as well, which has been long-standing. And what's interesting about the cardiac surgery is that they've moved from hospital level reporting to individual surgeon level. Just to give you a context within the NHS, it covers about 95% of all people receiving treatment in England and Wales effectively. So we're talking about something that is national in scope and pretty much all publicly funded hospitals. I say 95% because roughly about 5% would go to the private sector for their care. As with any of this type of reporting, there's always a concern about gaming, being risk averse. Oh, my outcomes are worse because actually I treat high risk people. How can we show that? Well, these shouldn't be unadjusted. They should be adjusted for factors which are going to influence what those outcomes are. Because the last thing one wants is that actually centres or surgeons or practitioners become risk averse in the patients that they select for treatment. So risk adjustment is absolutely key, but this is a constant ongoing process and it's never perfect. So where does cancer come into this? Well, as part of the Health Quality Improvement Partnership that I was mentioning, they started to commission national audits, and there are 5 national cancer audits for breast, bowel, esophagogastric, prostate and lung cancer. And effectively it was taking the data that we have from the cancer registries, bringing it to get together with our national data sets, so hospital episode statistics, and then also specialists in both epidemiology, but then specialists in the individual tumor types, and that would be surgical care, medical oncology, radiation oncology. And they would sit on these different boards and work out over a period of time, actually what aspects of care are we trying to audit? What are we particularly looking at with regards to improving quality and minimizing variation in processes of care? And what's been happening over a period of time? So I think a lot of the initial factors of an audit, or one thinks of an audit, is saying, well, actually, what services do they have available? And it, you know, even with the prostate cancer audit, it started off with, you know, how many radiotherapy machines do they have? Do they have IMRT? What type of biopsy are they doing? Are they doing template biopsies, or are they doing transperineal? So those types of information. But then to move on to transition to more process and outcomes indicators does take some time, as I'll explain from a data science perspective. And so we now have across these different audits reporting of post-op mortality, patient survival. I think interestingly with bowel cancer, they're looking at 18-month stoma rates, which is particularly important for those with rectal cancer, and to what degree people are having completion surgery after that. Lung cancer have their own rates, and they're very specific to those individual cancers, but there is that transition from actually being able to just say, well, this is what you have available and this is the proportion of X that you're treating, to actually what is the outcome of care delivered at your hospital. And it's very important that that transition is made. So when we talk about the National Prostate Cancer Audit, it always surprises me when I saw that slide that it started off in 2013, and I was very proud to be there from the start, really. And this was commissioned by NHS England. And from the very start, it had a methodological and clinical collaboration from the outset. So in terms of methods, so the Royal College of Surgeons actually traditionally had done a number, because surgery has been the domain where these audits have been done, and practice of you know, mortality and morbidity, etc. So the Royal College of Surgeons had expertise, but linked in with the London School of Hygiene and Tropical Medicine, so that the epidemiologists and health services researchers worked between the two, and they ran a number of audits. Then we brought the clinicians, so the British Association of Urological Surgeons and the British Uro-Oncology Group. So right from the start, there was clinical leadership and there was methodological leadership, and that was allied to data partners. So the National Cancer Registry were all formulated at that time. So from its infancy, it required that as its robust base. And there was general things when the audit was being set up as to what it was seeking to do. And I think at that time, particularly in the sort of early 2010s going forward, there was this issue of, are we over-treating people with low-risk disease? You know, we know that low-risk disease, actually, majority of patients don't get an improved survival benefit from actually having a radical treatment and can be managed on active surveillance. So are we treating too many? Then there was an aspect of under-treatment. So particularly with the trials that were ongoing, we saw that actually patients with seminal vesicle involvement, node-positive disease, actually could get real gains from having radical treatment with radiotherapy, for instance. So there was this notion of under-treatment of locally advanced disease. And just to give you an example of how audit has helped, if we take the under-treatment one, we were finding that at the beginning of the audit around 2015, about 40% of patients with high-risk locally advanced disease were getting treated on average, and now that's gone up to 70%. Similarly, with low-risk disease, there are about 15 or 20% of patients receiving radical treatment. That's gone down to 5%. So audit does make a difference. But we then wanted to transition to treatment-related outcomes. And so we went from 90-day emergency readmissions following a prostatectomy, but to things that are actually tumor-specific in terms of what are the main factors from the quality of care you deliver. So one aspect is issues in terms of incontinence or obstruction after a radical prostatectomy, that's the sort of RP, and then severe GI toxicity, especially for external beam radiotherapy. Now, the point being, if we saw earlier, we were looking at survival, but actually with radiotherapy and for prostate cancer or prostatectomy, we know that survival might not, benefits might not be seen for 5, 10, 15 years by time. So if you're publishing that sort of survival, actually care has just changed imaginably in that time. So you need to think of relevant, robust and valid indicators that are actually going to give you near real-time indication of the quality of treatment that's delivered. And that's why we went for more of the toxicity element when looking at that. So let me give you an example, and this is how we publish the data, and this is a radical prostatectomy example, 90-day post-op readmissions. So if we look at the x-axis, or we look at the graph, this is a funnel plot. We have dots which represent individual centers. The x-axis tells you how many operations those centers do, and the percentage on the y-axis is the proportion of patients operated who had a readmission within 90 days of that surgery. The factor with the funnel plot is that you have a mean level, and that mean is that orange line. So that's the national proportion. And with an outlier process, so what we're not looking at is, oh, well, that was 8% and that's 10%. There must be a 2% difference in quality. With an outlier program, given the volume of procedures are done, we're asking statistically those centers that seem to have higher rates or greater variation compared to the average. So you're an alert if you're 2 standard deviations away, which is, I'm not sure if you can see my cursor, which is this sort of marginally dotted line here, sort of a bit fainter. And then if you're 3 standard deviations or above that, you know, you're at the 99.9% limit. So that's 3 standard deviations away, and that would be an alarm. That's something where you would be informed, our Care Quality Commission would be informed that that's higher than normal. But like with anything, you need to check these things. It's not a case of, oh, well, we've recorded this data, we've used these data sets, your care is terrible, and we're going to publish it, and that's the end of that. No, not at all. We obviously get the data, we analyze the data, and then we go back to those centers that are seen as outliers, and we ask them, we say, look, we have found you did this number of surgeries, we found this many readmitted, can you check your own data? They then get a extract of that data and able to check it themselves, go through the case notes. And I think this is a pertinent example, because this was a case where from their side, their coders had coded in readmission wrongly, or there were day case procedures. And so we were then able to adjust those cases, and then their actual rate was 6.5%. The point being, this is not do or die. This is an iterative process. It'll either result in changes in our indicators, or it will result in changes in the coding mechanisms within the centers themselves. But communication and trust is absolutely vital. So that's just that example. So let's talk about radiotherapy. So what we really wanted was to have these clinically relevant toxicity indicators. And on the one hand, you can look at patterns of care, you know, how many patients are getting interventions for possible toxicity and any procedures. But on the other hand, what do the patients themselves say they're experiencing? And we used patient-reported outcome measures from a national survey that was sent to all patients that were treated radically with either surgery or radiotherapy within 12 months of that. And I'll come to more detail. So we have patient-level outcome reporting, but we also have these linked data sets that don't rely on clinicians submitting the data, but that uses patterns and processes of care that we can observe within our administrative data sets. And when it came to radiotherapy, as I said, we were looking at urinary toxicity and GI toxicity, and we developed an indicator, and we first validated it to see, well, actually, can it be used to compare different practices of care? The obvious one to do was, you know, looking retrospectively at the data sets, was to compare intensity modulated radiotherapy with 3D conformal radiotherapy. We know there's been very little RCT evidence in this, but did real world data give us a clue as to actually did a difference exist when it came to GI toxicity, and then other factors such as hyperfractionated versus fractionated radiotherapy. We then adapted those indicators for use at the provider level. So if I tell you a bit more about the indicator, now this took 2 years to develop, nearly 3 years of work. So this just didn't happen where we had an indicator which said severe GI toxicity. We had to get the data sets right, we had to do the cleaning of the data, and we had to think what was realistic. So what we did was we created a coding mechanism where we have lists of codes which represent particular procedures, so colonoscopy, sigmoidoscopy, etc. But then a series of diagnostic codes, again within these linked data sets, which are suggestive of radiation toxicity. So it might say radiation proctitis or something similar, or colitis. And it was the combination of these. Now you can't map it entirely to the standard reporting mechanisms in trials, but what it came about, if you had an intervention within 2 years of radiotherapy, that in itself, a GI intervention, that doesn't mean you have a toxicity. If you had a GI intervention, but a diagnostic code of radiation toxicity, that would be suggested, that would count as someone who's had an event. And we would follow these events over 2 years, and we would report the number of events out of all patients who had an event within 2 years of radiotherapy. And that's an intermediate term indicator, which gives us some idea. And we in validating that indicator, the sort of methods are in this paper, which was in the Red Journal. And we thought, well, actually, let's just test this. How does this look when we're comparing two practices? So IMRT, 3D, obviously we believe that IMRT is better and will reduce the rates of toxicity. But is that the case from the largest real world data study of all patients? Yes, it is. So what we found with real world data, this was all patients treated in the NHS between 2010 and 2016 or near enough. We found that IMRT reduces your rate of toxicity compared to 3D conformal therapy by 30%. Now someone will say, well, that's obvious, but equally, this then tells us that we have an indicator that's sensitive to what we're looking for. We've done further work. This was in the Journal of Clinical Oncology, where we compared treatment with prostate alone versus prostate and pelvic lymph nodes. Again, this is an area where we've not got randomized controlled trial evidence, but the question that we have is actually, is it safe? Like there's the debate about whether it improves survival treating the pelvic lymph nodes and prostate cancer. But the question of safety, what we can say from this real world study is that there seemed to be no difference or in GI toxicity when pelvic lymph nodes were incorporated. So I think that shows you that we do have an indicator that is valid, that can be used for comparing interventions. But the next step was, can it be used to compare the outcomes of hospitals? So where are we at with hospitals? So there are 52 centres, or hospital trusts we call them, that offer radiotherapy. There's another 5 or 6 what we call satellites, so smaller units, but they're linked in with the actual main radiotherapy centre. And so we developed this indicator to look at incidence of GI complications, grade 2 or above, within 2 years of receiving radical radiotherapy treatments. We were able to define the cohort. We were able to look at from that point of treatment, were there any interventions and diagnosis codes suggestive of proctitis or other radiation-related toxicity, and what were the number of events at the hospital level. We used funnel plots and we adjusted for important covariates, age, stage, socioeconomic status, and comorbidity. And again, this was designed to identify outlying performance. So what was the result of that? Well, if we look at the variation across centres, so the 52 centres here, so on the x-axis is the number of patients at the individual centres, which are demarcated with dots, the percentage grade 2 or above complication rate. So the average was 10%. Nationally, which sort of fits with the CHIP study, but their variation was 2 to 26%. Now, as I said, it's very hard to say with those between, say, 4%. So in between these, I hope you can see this, in between these lines, it's very hard to say whether that's actually a difference in quality or natural variation from a statistical sense based on the numbers of cases done. But what we did find is centres that were outliers. And those centres, we reported to them and said, look, your toxicity is 3 standard deviations out than we would expect compared to the mean. Please, could you look at your data? They looked at the data and they validated those results. Those results were, as we expected, near enough in terms of a percentage. Maybe a couple of slight changes, but it wouldn't have changed the fact that they were an outlier. So we had the process where we picked it up and then we fed back. I'll go into that process of actually feeding back and what that means and how that's dealt with. But actually that then had confidence in the indicator itself. So that was the GI indicator, and we've been using that since 2018 each year. The factor then is about the patient survey, because I mentioned, well, these are from the linked data sets. Well, what do patients tell us? So part of the Audit's initiative was to send out patient-reported outcome measures and experience measures of treatment. We used a validated EPIC 26, which is used in many of the radiotherapy trials for prostate cancer, as well as the EQ5D5L. And that was sent to all patients who had radical treatment within approximately 18 months after diagnosis. We had a 73% response rate, which I think those who've been involved in PROMs knows that that's very high. And I think it also tells us that actually, people are invested in their care. When they understand what's happening, they are prepared to receive and reply. And actually the completion rates, it's one thing responding as a response rate, but the completion rates were very high as well. So this was a collection over sort of 12 months around 2016, and then we had a further collection period in 2019. But back to how we worked it out before in terms of the validation, we used it to try and compare different processes of care, first of all, before comparing hospitals, because it's very, very, very different. So you want to make sure we know what we're doing. So again, this was another paper published in the Journal of Clinical Oncology, where this was the largest real-world patient-reported outcome study comparing those who had hypofractionated radiotherapy for prostate cancer compared to conventionally fractionated radiotherapy. And there was no difference found between the two modalities, which again fits with the randomized control trial evidence, but does give confidence moving forward that actually we're not getting something completely out of the ordinary or spurious. So a similar process, we've compared it between pattern mechanisms of care. How can we compare it in terms of across different providers? So we did a risk adjustment, again, for age, comorbidity, stage, and we looked at outcomes, and the outcomes that we could get would be sexual function, bowel function, urinary irritative score. So those are important factors, especially from the patient perspective and understanding the quality of treatment. So again, funnel plots, so low is bad in terms of, well, not bad, it's not as good as a high score for the mean sexual function score. And interestingly, it's not just about those you're picking up that have worse outcomes. When it comes to benchmarking, you want to pick up those centers that have better outcomes. And so we had 4 positive outliers. So these were centers that had better than average outcomes when it came to sexual function after radiotherapy. Mean bowel function score, so higher is better, lower is worse. Again, not many outliers, it's quite closely matched together, so we didn't find anything specifically that. But interestingly, what we found is that the outliers in subsequent years on our, so how's the best way to explain it? On our first indicator, which was looking at the rates or the proportion of patients getting a GI toxicity within 2 years of radiotherapy, those centers that were outliers on that indicator also were outliers on our patient-reported outcome measures. So even though it was slightly different time frame, using 2 different measures of toxicity, one patient-reported outcome measures and the other these linked data sets, there was a correlation. So there's something there. So it again gives you some idea of the system, and actually, as I said, when we go through the process of validating that with the centers, they've come back and corroborated those results. So I'm just going to stop a share quickly and show you the website, just to show in terms of the interactivity of it. So you'll see me briefly for 2 seconds. I'm going to share this. So this is the National Prostate Cancer Audit website. You'd go to provider results. I'm going to show you the Clatterbridge Centre on this centre, because as you'll see, so for those that don't know, Clatterbridge is a very large centre in the northwest of England, in Liverpool, which has been a centre of excellence for a number of years. A number of trials come out of there. But interestingly, when we look at the outcomes, so if we go to compare provider outcomes, we can see Clatterbridge. So again, similar. Can people see this, by the way? I hope I'm not just...
Yeah, no, we're fine. Yep, fine, okay. Ajay.
So you can see these are all the centres providing radiotherapy, differences in volume. This is the Clatterbridge. So it had, and this is for the 4th successive year, excuse me. I think you all need a break as well. I can talk and talk. But, so as we can see, they were a positive outlier. So they have the lowest toxicity, and that's 4 years running. But you can see there are other ones that had better than average. Oh gosh. They had better than average toxicity. And so, but you can see the variation, and you can see that they're actually outliers, negative outliers. Now this one, for instance, you would think, well, why wasn't that declared an outlier? It's because of the low numbers. We can't say with statistical confidence that that's a true outlier. That's just in terms of explaining the way that the outlier process works. If you look at sexual function, so we can see that it had better, higher than average reported outcomes for sexual function and also bowel function. So there's this consistency here, high performer on different indicators. It's a high volume center, and I could show you ones that were not so good, but we have this interactive framework here, as you can see, and depending on the center, you could look at the outcomes after prostatectomy. So that's available to the patient, and there are other elements about what they thought of their experience of care, disease presentation. So that's all part of the outcome reporting. You're not just talking about the availability of services. You're talking about the types of disease that come, men's experience of care, and then moving on to outcome measures themselves. Let's get back to the presentation. So, it's a $1 million question. Does it actually improve quality? So I've put yes, but it's a tentative yes, because actually it's an area that's not that well researched. It's not that well researched because there are not that many countries in the world that do public reporting of outcomes. It's not covered many interventions. It's predominantly surgery and mainly cardiac surgery itself. We're still in an evolution of the quality of data sets, and we're still in a position where we don't know to what degree patients then drive the service or how the service changes. But there's been a lot written in the literature about what is the mechanism for improvement. So going back to the original point about some of the Tony Blair era and choice and competition. So on the one hand, it could support choice. So patients move, centers think, oh no, we're going to lose patients. We need to improve our outcomes because our outcomes aren't so good. Or there could be a reputational effect from the public reporting where you see that you're not doing as well as you should be. You think, well, why is that happening? So that's the intrinsic motivation element. So the patient choice is, you know, the change selection pathway that actually, you know, you're losing money here. But the reputational effect is that intrinsic motivation. Benchmarking of best practice. So if you know, and I'll come to Clatterbridge in a second, if you know that there is a centre that's doing better than the others, what is the pattern of care there? What are they doing differently? And then the outlier program itself allows trust to review process of care. So at the very least, you're making sure that actually, although it keeps everyone around the middle, or is mainly looking to see if everyone's around the middle, you're also trying to prevent actually some real disaster happening at a hospital. You don't truly know until you measure the outcomes. No one knows until you measure it. Anyone can say they're providing excellence in care, but you know, to this day, if you don't measure it, you really, really don't know. And that's, and there's a sort of cultural element to this, which I'll come to in how people deal with outcome reporting. And it's not easy, and I'll give you some anecdotes shortly. This is just a piece of work from the National Bowel Cancer Audit, which was published in the BMJ. And they were just looking at the fact that 90-day post-op mortality over the years, this was the introduction of outcome reporting, and they did see a reduction. You know, it's not high. You wouldn't expect it to be too high, 90-day post-op mortality. But the reduction after the reporting was such that it wasn't expected by chance alone or just natural reduction in those rates. So something is happening, but we're not quite sure how or when. So in the UK, what has been the impact? So going back to benchmarking and internal audit. So our centre, I can speak from experience, so it's not a case of I've been pointing the finger at other centres in this role in the National Prostate Cancer Audit. Our centre, my centre, came under the spotlight, and it's not easy. You go to your colleagues, many of them have been there longer than yourself, you say, look, the early results from the audit suggest that we're not quite an outlier, but actually our rates are much higher than we expect. It's not a nice thing to deliver to your colleagues who are extremely competent, research active, busy department, tries to integrate all the sort of new things as and when. And it takes a bit of time, and that time can only recede to improvement if you start to look internally. So what happened is that we did an audit of 2 years of our outcomes on the basis of it, and it corroborated the findings of the National Prostate Cancer Audit. And it was a surprise. People weren't expecting it to be pretty much there or thereabouts. And I'll explain what changes happened, but it is hard for people to realize it, because actually what came out of it is that we weren't doing anything wrong to what was practiced in the last trials, for instance. And I'll explain what the difference probably were, but you can't have we need to start a quality improvement culture. And if we have those outcomes, it triggers internal audit, which then identifies area we can improve. When it comes to benchmarking best practice, we asked Clatterbridge, you know, what are you doing? And they've presented. And it was amazing how much they'd iterated their process of care, how much they'd changed over the years in terms of margins, bowel protocols, the use of fiducial markers, lots of different elements which are available to everyone, but they'd done their own internal audits over the years. That quality improvement process was constantly happening and resulted in them having rates of GI toxicity of 3 or 4%, which is amongst the lowest that you can get, even better than some trials. So it is feasible within the context of what we have already. The other factor in outcome reporting is that the surgeons, I've found when we were reporting back to surgeons, were much more on top of it. You know, we were getting responses like, oh, did you pick that up? Oh, yeah, that surgeon's left now. Or, oh yeah, we did that procedure a couple of years ago, we've retrained in a different one. So people do know. sometimes that, you know, you just have to be able to call out, but do it in a robust manner. So as I said, in terms of changes, what we've done ourselves, you know, we've changed our margins, our dosimetric constraints have changed. We're working on whether we're moving to fiducials and spacers or fiducials alone. The communication and team working, you know, it was one of those, we had peer review running for the last 2 or 3 years, but actually our peer reviews expanded because we now have not just the dosimetrists, the physicists, we also have the onset dosimetrists, the onset radiographers, you know, who are making the shifts, and now they're bringing up patients. So actually these shifts are quite big. You know, what do you want to do? Do you want to do a replan now, or do you want to carry on? So these small things and bringing in the wider team has allowed us to get that transparency, but it does take time and it has improved things. And I think just the overall thing was that these improvements in the value of treatment has been given by iterations in practice rather than, you know, buying something extraordinary that wasn't available. But it's hard work. It's not easy to integrate these things, but you have to invest the time in doing so. Just wanted to give you a quick notion of what happens, because I brought up this thing of patient choice, or what happens in healthcare markets when we don't really have outcomes. You know, on the one hand, I said in the NHS brought in the ability to choose your hospital, but on the other hand, furnished the population with very little information on where they should go or how they should get information. And I think this is a good precursor. So this is a piece of work that we published in the Lancet Oncology, which was looking at national data sets, looking at radical prostatectomy actually. And just a couple of slides just to make it a bit more jazzy for you towards the end. But we were looking, what we found effectively is that even with the public sector hospital, public sector, competition in cancer care was driving up costs, but there was no clear impact on outcomes. And I'll come to why. So if we look at a map of the country, so you see the green dots in the corner, and it's all patients who had a radical prostatectomy who live close to a centre in Norwich, and they had their treatment in Norwich. Large centre, very centralised. The people in the yellow orange dots are those who live nearer to Norwich but went elsewhere, and those in the red dots who live closer to another centre who went to Norwich. But by and large, this is what we expected. When the policy came out, we thought no one's going to move, maybe 3 or 4%, everyone will go to their local centre. What we found is patterns like this. So this is Bristol, southwest. So all the green dots are patients who live near to Bristol and had their treatment there. The crosses you see are all radical prostatectomy centres, and there were 65 centres at that time. The blue dots represent all the patients who had other centres closer to them who decided to travel to Bristol to have their radical prostatectomy. The question was, well, what's going on in Bristol? But we kept seeing it in different centres. It was happening in Cambridge, it was happening in other centres, which we wouldn't have necessarily expected, you know, this mass movement. And so one of the questions was what information they were using. We didn't publish outcomes at that time. What was driving it? So we wondered about reputation. So if you Googled right now, best prostate cancer surgeon in the country, one of our large tabloids, the Daily Mail, has a top 10 list. But if you look at that top 10 list, I'm not saying for a second that actually you would argue with people on that list. They were all well known. I don't know, no one can tell me if they were any good at operating because we didn't have the outcomes, but it was an unreasonable list. And patients, when I spoke to them, because I did a qualitative piece of work with this, said, yeah, well, we did use that list. That was the only thing that was available. But there was another factor. We found that 1 in 3 people were shopping around, not 5%. They were younger, fitter, more affluent. So there's an equity perspective. And the other big driver, so the centres which had a surgeon that was on this list gained the most patients. But the other factor was whether they were an early adopter of robotic surgery. So at the time, pre-2010, so we were looking at 2010, 2014, there were about 12 centres that were robotic surgery centres. You can see they had the greatest gains in patients. So these are all individual centres. And this is gains over and above what was expected given their catchment areas. And these were losses. So we could see all the ones that gained was robotic surgery, you know, and that was borne out in the qualitative work. But actually, what happened to those that were losing patients? They actually closed. You know, we had this evolution where you had centres winning, and no one knew this was happening. But actually, on a national level, centres were also closing. Question one could ask: were these centres have worse outcomes than any of the other centres? No. What was happening then? Why were they closed? Well, there was other policies saying you needed to do a number of minimum surgeries per year. So if you didn't do enough surgeries per year and you were losing patients, you're stuck. but it wasn't necessarily based on quality. What happened to the other centres? Well, they got robots. And so in this period of time between 2009 to 2017, there was a reduction in centres from 65 to 50 centres, and there was an increase in robotic surgery from 20% to 90%. Now, there are advantages of robotic surgery, but there's certainly not advantages in terms of oncological outcome or functional outcome that we've seen already. So this is just an example of that, patients are responsive to potentially difference in quality. Doctors want to be able to provide the best care, but if we don't have the right incentives, you can change both the structure of your service without necessarily improving quality or inflate the cost of care. So there's just these factors to consider and why outcome reporting is important. And I think particularly from the US perspective and other market economies, this is very important. What about radiotherapy? Well, I did do some work, if you wanted to read more, is in the Red Journal. And we found that 1 in 5 people were moving around, again, younger, more affluent patients. Tended to be, interestingly for prostate cancer, patients were more likely to go to centres that were early adopters of hypofractionation, which makes sense. If someone down the road from you is offering 4 weeks treatment rather than 8 weeks treatment, that makes sense. But again, this is something that people had to find out. And that's what comes out from the qualitative work, that people have to do their own digging. It's not a transparent process, it's their own networks and knowledge. And this is just a map for radiotherapy around the Christie. And I think just the only interesting thing about this is that these satellite centres, which are designed to improve equity and access, however, are bypassed because patients prefer to go to the mothership as such, or the main cancer centre. So we have this dynamic within the NHS where we need more centres to improve equity and access, because we know people aren't able to receive that care. But with that does come a certain loss of efficiency in the system. But you might have to accept that if you want people to actually receive the treatment that they need. So that was just something to say. So to conclude, cancer outcome reporting is here to stay. I'm proud that the Prostate Cancer Audit is the first radiotherapy outcome reporting programme, and we continue to refine and iterate our processes and considering other outcome indicators. For instance, we've developed one for skeletal related events, which one day we'd hope to use for those having systemic therapies, for instance, and working with the bowel cancer audit, looking at severe toxicity after chemotherapy admission or admission after chemotherapy administration. It does take time. You need clear political commitment and data infrastructure. But for the actual cost, and I'm sure people will ask for the cost, it's actually relatively cheap for what an audit itself delivers nationally in terms of intelligence about the quality of treatment and variation in care. But methodological and clinical collaboration is absolutely critical. We've shown that we can use different types of data, patient-reported outcomes, engage patients, but also data science. And we'll continue to develop these indicators in other tumour types. And fundamentally, we're trying to support quality improvement, patient choice, and also identify high-value care. Just a name of the paper to which this leads to, and the National Prostate Cancer Audit Team. And I thank you very much for your patience and listening, and happy to take any questions.
Ajay, that was absolutely brilliant. Thank you so much. Gosh, so a lot to think about there. So how, I'll just start off, but please either put up hands or I'll shout you in. How much could this be transferred globally then? And how much would it take? Is it thinking about the policy? Is it going to work in different places? What's your thinking there?
So I think it could be transferred immediately. I think it depends on the context. So there are a number of countries that have good data science, that published epidemiological studies, but this is one of political coordination and access to data. So for instance, obviously we're in the UK, there's no reason why other high income countries across Europe, North America, Australia couldn't be doing this very readily. Obviously there's the internal processes of where that data is and how it can be housed and who funds it, but actually I don't see any reason why, if it could happen here, why in terms of from a methodological perspective or a cost perspective or a need perspective, why that wouldn't occur. I think from a global perspective, I think one of the things I do present on is the use of real world data. And I think that infrastructure, both in terms of needing cancer registry and the methodological support to work with clinicians more globally in the low and middle income setting to set up these types of initiatives will take a bit longer.
Okay, interesting. So dealing with those two, I don't know if Lisa, Ted or Paul want to come in on the lower and middle income countries. How important is it, and how could that be sort of accelerated? What's your thinking?
Well, this is Ted. I'm happy to jump in. I mean, I think this is critical, as we're trying to roll out, in my case, definitive radiotherapy for cervical cancer. If you can't deliver the right care or you have unacceptable toxicity, then you're not helping people. But if you don't track the outcome, you don't know. And if you don't track which patients are being treated within, 6 weeks of diagnosis, you don't know. So I think we have the opportunity to kind of leapfrog in those centers that are seeing high volumes of, in my case, cervical cancer, that have pretty good radiotherapy. And we need to, use the examples that we have from UK and elsewhere to track patient-reported outcome and oncological outcomes. We have cell phones. We have translated patient-reported outcomes. So we should take advantage of the opportunities that we have now that we didn't have 5 or 10 years ago.
Should this, do you think, be put into policies of radiotherapy rolled out in countries? So, if a country is funding radiotherapy, should they also insist that there should be some outcome measures?
I certainly hope so. I mean, it's an expensive intervention. We're training a lot of people. We're buying expensive equipment. We shouldn't be treating people without tracking outcomes.
Any other thoughts, Lisa or Paul?
Well, I just want to pick up on something that Ajay said that I wrote down, and it's this quality improvement culture. So I think even adding on to what Ted was saying, and Ajay, you alluded to this, it's maybe a challenge or a difficult when you get some of the data back and it's maybe not what you expected. But then if you're going to instill this thought of this quality improvement culture, and maybe you're working in a situation where the data has to start to be collected. So the data collection process started in the UK many, many years ago. But I think it's how do you roll that out? How do you implement that as a culture while you're asking centers and physicians and patients to report this data?
Yeah, no, so it's a really good point. So I think actually quality improvement, I think with radiation oncology full stop, I think we pride ourselves on our quality assurance processes, which is in fact very multidisciplinary. But I think actually in the starting point, I think there's not enough peer review full stop. We have centers that are incredibly busy in the low and middle income setting where people are having to do multiple tumor types with different types or modalities of radiation therapy with colleagues who are equally busy. And so to ring fence the time needed to appraise each other's work, to find out areas for improvement, to see where guidelines can come in to help, does take both a change in culture, but we have to try and promote that to some degree, and whether that's a staffing factor so that we have more staff that allows that, or whether actually as a starting point we need to, and this one of the things we've done with some cloud software or testing, it didn't work, the cloud software specifically, but that we would try and do remote peer review to begin with, that actually if there were plans that people wanted to appraise, maybe actually budding up with international collaborators or other countries within a particular continent, for instance, that can happen. I think that's the basic minimum. Even with all the sort of automation of planning and things, you still need basic 101 peer review. If you don't have that, then actually collecting through a big data registry isn't going to be that helpful, because you've not started at point one, which is, am I actually signing off a plan that's going to deliver what it does and is not going to harm the patient? Once we started that process, is much easier. The difficulty we had in the UK is that peer review process was happening, and so people turn around and go, what the hell's happening? But then we also realized that actually there's so much of radiotherapy delivery that we're not involved in as clinicians. We do the contouring, and we said, oh, well, we check everyone's contours, but we don't do the setup. We don't know what the bowel and bladder was like during the treatment itself. We don't know what shifts or margins were done. So that's why we had to pull everyone in, and that's where we ended up getting to a better place. So when we realized that actually quality in radiation oncology requires the whole team, and bringing that together in a format that works in peer review, then we can move forward, I think.
And how do we think it could work in the high income? I was thinking the States. I know Louis had to drop off, but perhaps perhaps Mary or Mel, how can that, what are the challenges going to be there for choice and competition and public reporting? Are they going to lynch each other? Or
so Pat, in Canada, there's been public reporting of some cancer outcomes, but care is provincial, so it's organized provincially. There is national organization that is multidisciplinary, CPQR. CPQR is a program of quality radiotherapy, and they just published the guidance for standardization of patient-reported outcomes, but there's no sort of nationwide collection of complications or toxicity. One thing that I wanted to ask Ajay is, what about reporting local control? Because, you know, one way of lowering complications is to not give optimal dose and undertreat, and you're going to have lower complication rate, but you also want to have optimal local control and optimal outcomes. And have you, do you have any measurements of you know, cancer outcomes other than complication rates in the UK on the population level?
Yeah, good question. So for the other tumor types, we do in terms of survival, but they would be more relevant for esophageal cancer, for instance, and I think bowel cancer. Your point about relapse or recurrence or the actual adequacy of the treatment itself, yeah, that's exactly what we're working on at the moment. And you know, you're at the behest of whether you can get the grant funding to actually do it as a program of work. So it's possible, the data science is available to do it, but the validation process that takes is, you know, 1, 2, 3 years. So I think it's definitely doable. That will be the future, moving towards looking at relapse or, you know, recurrence or progression for the different ones. So yeah, there's no reason why it can't be adapted, is a short answer, but it does. It's not something that can be done quickly.
I have another point that I wanted to make, is that we have literature of the cost or penalty we pay for waiting times and waiting lists and delays in treatment, but there's very little literature on the cost of poor quality. So if you don't get a local control, if you get high complication rate, what does it mean in economic terms? I don't know, Ajay, are you aware of this literature in radiotherapy specifically?
Yeah, it's again a really good question. And I think it's something that once you have this as the infrastructure, then you can add that on, because we're using linked data sets, that comes with the HRG codes. So costing would be feasible. So when I showed you that example of IMRT versus 3D conformal radiotherapy, given the reduction in interventions and diagnoses and other issues, you could probably show quite a different cost differential. So I think it's absolutely ripe for that, to be honest, and to inform reimbursement subsequently.
I had a question.
Okay, sorry, do come in, yes.
Sorry, I had a question regarding incentivization of hospitals to participate in something like this. So right now, I can see that it's not every hospital, obviously, that's participating in the UK. Since you've started this whole process, have you had more hospitals join? And for those hospitals, have you looked at how they were incentivized or how they decided that this was something that they would like to participate, having seen what's been happening? I think that's quite important in terms of trying to get, obviously getting a government policy to make people participate would be good. But in terms of voluntary participation, how do you get that to increase over at different countries and also in the UK?
Yeah, good question. So sorry if it wasn't clear. So for the NHS, all hospitals are participating. So all of them, and it's a requirement, and that's where the political element comes in, because this has been requested by the National Health Service that outcome reporting will happen. As to the development of indicators, they didn't say we want the audit to produce radiotherapy outcome indicators. That was, we were allowed to try and develop them organically, but the actual reporting of them and then the monitoring of them. So for instance, if you are a outlier hospital, that information, and that's confirmed, that goes to our Care Quality Commission, which oversees quality across all hospitals and reportable to the government. That goes to the chief executive of the hospital, as well as the sort of head of the radiation oncology department. So there's a definite sort of escalation within that. And for those who are close to being on that edge, again, there's an escalation policy there as well, and not as dramatic. I think with the private sector, they're not inputting it at the moment, but I think there's some elements of how that data is collected for them. I think from a US perspective or other countries, I suppose, I mean, I went to a talk by Justin Beckelman, I think his name is Justin Beckelman, so apologies if I've got it wrong, a couple of years ago at Estro, and he was mentioning about different policies that insurers are looking at to try and improve quality. And I suppose if from an insurer perspective, they're being asked to fund and reimburse different elements of the pathway. I suppose it's to reverse the question, to what degree is there an ability to mandate outcome reporting to justify then the reimbursement and to actually show is there a true difference?
That's really interesting. So thinking, Ajay, so it sounds as though this is all really important, and it sounds as though all the things along the way, like getting the data on actually what's happening in radiotherapy and all these other things and real world analysis, this is all the way to go. And you've got the tools, we've got the online presence to do all that reporting. So if you had a blank piece of paper, if we were, say, going to have something globally in radiotherapy, whereas we took it upon ourselves to say, right, this is what radiotherapy needs from all these, quality, reimbursements, access, the whole thing. What are the barriers and what would be the roadmap? Are there some leaps you could do, or is it going to have to be each country try and do themselves? What's the blank piece of paper got on it?
Oh gosh, I think it's really influenced by each individual health system. If you've got your mix of purchaser providers, the way that patients consume care, all these things will make a difference. The cancer registry setup, how can we monitor patients effectively? I mean, the whole COVID-19 situation has told us about, real-time data and to what degree it can influence our patterns and processes of care. So it would be hard just to say something on a global perspective outright. What I would say, though, is that the culture of transparency and quality improvement is germane to every health system in the world. I think it should be absolutely required, and I think people would agree with that. I think we need patients more involved in their care to understand that actually what it is that they're receiving and how differences could impact on them. I think from a point of view, from an individual country perspective, on block, for instance, I can talk about Europe. I think we need to win over hearts and minds from the clinical communities as well as the policy communities. I mean, with surgery, I think this is much more readily done because there's a culture of it. With radiation oncology, there'll be people who obviously don't know that this exists or this is happening. So I think we need to start that message first and foremost that it's possible, and then we need to refine it to make sure that the indicators that are produced are relevant and context specific within those health systems.
Yeah, Mary's just made the good point that if you have a critical mass of centres reporting, then others will get on board. Do you think? Oh, Mary, speak. Yes.
ICOM. I can see the ICOM question. Mary,
yeah.
Go for you.
Yes, Ajay. Yeah.
So I can just say, you said ICOM is leading a global effort on health outcomes reporting. Query any plans to align. So I think another paper myself and Yolanda Levens a couple of years ago looking at value-based radiotherapy, very much looked at, how do you measure value in radiotherapy? How do you measure outcomes? And we did look at the outcomes that ICOM suggested, multidisciplinary, but it was one of those things to how do you action that? So I think they start to look at slightly different things, but there were a number of different proms, different scales, different indicators. How do you institute that? How do you measure that? What is relevant? And that's the bit which I think we've got to try and simplify. ICOM have their set of indicators. EORTC have their set of indicators. There's something called the Pioneer Group that's also looking at a set of indicators. Everybody's looking at indicators for looking at quality, but no one's measuring it or instituting or doing the hard bit, which is, we know we can measure quality, but it's expensive and requires some thought to put this back together in a strategy. That's what we need. So it's the implementation science bit we're missing.
Okay, so the implementation science, exactly. And so as a radiotherapy global community, should we have some thought on the standard or minimum or some sort of...
Of course.
Could something come as saying this should be a minimum standard and all those sorts of things? That would be really helpful for the world, wouldn't it, really?
Yeah, absolutely. And I think it starts with understanding process and a variation in care. So it's fine to, we started this process with an organizational survey, which told us what's the availability of services, and we had huge gaps across the country in brachytherapy access. As you know, Pat, not everywhere has it. We have, of the 52 centres, 32 offer low dose rate brachytherapy, 11 offer high dose rate brachytherapy. The people who'd have to travel 150 miles, or which is not much, I know, in Canada and Australia and the US, but for us that's a lot for the UK setting. So I think it has to be a commitment to understanding actually where access barriers are. We then, the next level, which is what we did in the audit, is to talk about variation in process and outcomes. So you could look at variation IMRT uptake, for instance. You can look at variation in indication for treatment. Are we treating people who could be cured with curative treatment? We think it's obvious, but it doesn't happen. 50% of people with chemo who have a bowel cancer surgery with a Duke C cancer or stage 3 cancer don't get chemotherapy, even though we know it improves survival. So we have huge access gaps and differences in management. So I think keep it simple: availability of services, access to services, differences in processes and variation to care, and then outcomes. Those first three, everyone can sign up to. The fourth one's harder, but that's how we're going to get true quality improvement.
Ajay, that's brilliant. We'll have to stop now, and I know Mary's got to run, but I think Mary's comments there, global consensus, I think there's a bit that says, let's do a little bit of work about that global to start where you're going to, and then everybody can join in. Ajay, that's absolutely brilliant. I was going to say, if people will put this talk online and everything, and the sort of round table afterwards, and I know if people wanted to use Slack, whether, I don't know if Sam's talked to you about whether you would respond to, later if people got in touch with you about things, that would be great, Ajay.
My email's there, so please.
Yeah, no, thank you, everybody. And everybody, thank you very much for coming today. We'll have another session in a month. Just to say, I've been working with Anthony Zeitman on an editorial for the Red Journal that's going to come out talking about political advocacy for radiotherapy, and perhaps we'll have a session on that. So any thoughts on what we should have a sessions for, please let us know, and hopefully we'll be improving our communication amongst us and expanding the group. But thank you very much all for your help today, and we'll meet again in another month, I hope. And Ajay, fantastic. Thank you so much.